Hi, this is Larry Bauer, Chief Executive Officer Emeritus of the Family Medicine Education Consortium. And I'm excited to have an opportunity to hear from the team that has created a community-owned health plan in the Ashtabula, Ohio area. And you'll hear more about that through each of the speakers in just a moment. The people who are on this presentation include Dr. Mark Potts, who was the superintendent of the Ashtabula area city schools, Casey Billington, who is in charge of nurse navigation services, Maria Fowler, who's an owner of Kaufman's Pharmacy in Ashtabula, and Bryce Heinbaugh, who is a health insurance agent who has really been the architect behind what I think is a really brilliant innovation. So we have a little bit of time issues here because we have to get Dr. Potts off to the church on time for his daughter's wedding. So with that, I'm going to turn things over to Dr. Mark Potts to give the audience a little background.
Okay, thank you, Larry. Yes, I'm Mark Potts, Superintendent of the Ashtabula Area City Schools. I'm really just a small piece in this, but about 3 years ago, we recognized that we were not getting the health outcomes that we wanted to off our traditional plan. We also, the cost kept rising and rising. And we're in a school district that's 100% free lunch. We don't have a very strong tax base. In fact, we haven't passed a levy in over 20 years for new operating money. So you can only do more with less for so long. And we had to look, at some other ways to operate more efficiently. So a circumstance happened that we were upset about. It appeared to be a pretty big lack of transparency on the folks that we had been managing our healthcare plan for a number of years. And so that's when we looked Bryce's direction and to look for some solutions. And that's kind of how things got started.
And why don't you tell folks what's happened over that 3-year period of time? What's been created and what are the results of that creation?
Okay, so, well, that's the exciting part, was the levy we failed that year would have generated $1.7 million. We asked the taxpayers for. In Ohio, it's a little bit tough because in Ohio, if you want to generate money for the schools, you have to ask the taxpayers to vote themselves a tax increase. And that's kind of a tough sell. So the tax levy failed. We were looking at making some pretty serious cuts at the end of the year. But the program, the Health Rosetta model that Bryce brought to us, what we were able to do was to run our traditional plan that we had negotiated with the union, with the unions, rather. It was a classified and certified unions. And then we were able to run this other model parallel with those and give people the choice. So initially, I think about 30% of the employees joined the new model. It grew to over 50%. But just with that amount of people on the new plan, the first year, based on the 2019 baseline, the next year we saved $2.4 million on the first year that we tried this. We just recently finished the second year, and that was another $2 million in savings. So it's worked out very well. We've relocalized to some degree, and Maria's on here, especially with our pharmacy benefits. We've kept the money in town, and we provided, the exciting part is that we've provided better service for our employees and better outcomes for less money. So it's really a win-win-win all the way around.
So that's fantastic news. I'm sure the taxpayers are happy about whether or not I don't know how much they know about that, but those savings are pretty spectacular. Now, I understand, Dr. Potts, that you're leaving your superintendent position and you're getting involved with this community-owned health plan at a broader level. Could you comment on that?
Yes, absolutely. Once I saw how well this plan works, how replicable it is, and I said everybody should be doing this. And as a superintendent, I had followed the status quo because that's all I really knew. I didn't know otherwise. So, but now that I do, I really want to spread the word. I think it could, especially in the public sector in general, schools, municipalities, I think they can save a tremendous amount of money and give better outcomes to their employees, which is what we all want. So yes, so I'm stepping down as superintendent. Well, I was supposed to step down July 31st, but I'm apparently interim right now while they're still looking for a replacement. But I plan on doing this on a much more full-time basis. So I had 3 years left on my contract, but I just felt like this was more important. I could make a bigger impact if I went this route.
So this will give you a chance to become really an ambassador for a community-owned health plan model, helping other superintendents and other civic leaders to understand the value of this.
Yes. Yep. That's my hope.
That's fantastic. Thank you for doing that. So I want to turn things over to Bryce now. Bryce, do you want to talk a little bit about the overall plan? And Mark, I understand we want to keep peace in your family, and you've got a wedding you need to go to. So if you need to leave at any point, please feel free.
Yeah.
Thank you, Larry. I appreciate it.
Yeah, Mark, we appreciate it. I had mentioned to Larry, we may just have you for 15 minutes today. So you've met that. And if you need to run, feel free to. I can certainly clean it up from here. But so again, yes, my name is Bryce Heinbaugh, and I have the privilege to kind of introduce myself as one of about 200 accredited Health Rosetta advisors around the country. We're from the Rust Belt of Ohio, even in some ways considered Appalachia, but Ashtabula County, Ohio, far northeast corner. Why I give you the geography is because we're right in the middle of two very large, nationally known health systems, Cleveland Clinic, UPMC, and we honestly, as a community, we fight the battle of healthcare costs. And the dollars that we see leaving our community to these very large nonprofit hospitals, and in some cases we call them financial institutions, those dollars have become what Dave Chase at Health Rosetta calls as the largest legal wealth transfer in America. And so what we're attempting to do was to slow down the dollars leaving our community by taking healthcare back for the school district. And what that meant really for us was to create a healthcare plan that was community owned and not Wall Street owned, and really doing things like value-based primary care at an on-site level where the DPC doctor is coming into the schools each week, where a community pharmacy is the focus of our pharmacy plan, where we made generic drugs completely free at that pharmacy only in town, not the big box stores. We have, sitting next to me is my business partner and clinical head of our concierge nurse navigator program, Casey, where we have this concierge nurse that works with the doctor and works with the pharmacist, and we technically are running advanced primary care siloed, but it's active and it's working and it's patient-centric. And by eliminating the misaligned financial incentives of the status quo healthcare model, we have been able to save, Dr. Potts mentions $2.4 million in the first year. It was actually a 21% year-over-year savings in that very first year. And for us, what happened is it became the domino effect. And I'll just share real briefly, because then I'd like, Casey or Maria to take a little bit of this too. But the city manager of our local municipality, the city manager's wife teaches at Ashtabula Area City Schools. He and his family take the city school healthcare plan. They experienced it firsthand amongst some situations for their family. And the city manager's experience, he went back to his union groups, went back to the leadership of the municipality and said, we need this for our city, and we've got to figure out a way to get our unions on board. Short time after, Casey and I presented to all of their unions, fire, police, sanitation, as well as other leadership council. And it wasn't very long until the city of Ashtabula adopted this same exact model. Other private sector employers have done so. Maria Fowler is a staple part of with Hoffman's Pharmacy as our local community pharmacist. The direct primary care continues to be replicated. We actually went so far, we maxed out the panel for the DPC doctor within the first 12 months. We just hired another direct primary care doctor, bringing him into our community, all value-based, no fee-for-service misalignment. And quite honestly, as Dr. Potts alluded, nearly another $2 million saved in year 2, and we just entered the contract period for policy year 3 for the schools. And for 3 years in a row, their healthcare costs are going down. And as Mark's treasurer would say, right now, if he were on the call, Bryce, this is the most money we've ever had in our healthcare account. And I really can't even believe this has happened. And so we've saved no teacher cuts, no transportation cuts, nothing. And that's the meaning and power behind this Health Rosetta model, but a community-owned health plan, not Wall Street owned. So with that, Larry, I'll turn it back to you. Oh, you're muted, Larry.
Yes, I am. Sorry about that. So, Bryce, thank you very much for that. Very exciting. Casey, do you want to talk a little bit about the nurse navigation services?
Sure. So each nurse is assigned a business that is their client, and those employees, their families, get to call the nurse, build a relationship with them, so the nurse can help shepherd and guide them to high quality providers. They can help support them through complex diagnoses and help them understand a new surgical procedure or something that they may be having. And in conjunction with that, they will work with a direct primary care physician for any type of specialty services that a person may need. And the direct primary care doctor is also able to build that relationship with the pharmacist in the community. And the three of them can collaborate together to help maximize the benefits that the school district and other employers are already offering their employees. So having all these services localized within the community and readily available for members and easy to access is really a fundamental foundation to ensuring that people have access to high quality care. Maria, you're back now, but I was just talking about how the direct primary care physicians and the nurse can work with you and your team at the pharmacy to help bring high quality care options to people within the community on these healthcare plans.
Yeah, that is one of the nice things about working with this group, is that the relationship that we have with the nurse navigators and the DPC has always been, it's a close working relationship and one that's easily accessible for all of us. That's one nice thing about having a community pharmacy on board with a program like this, is when you look for one of the employees or you have a problem that needs solved that involves the pharmacy benefit, it's nice that there's a person, me, who, even my internet cuts out in and out every now and then, I am accessible to this group. I can, I'm one phone call away, one text message. My staff is all there for them, and we get problems solved immediately if anything comes up. So it's really been a nice working relationship. I'm honored to be a part of it, but I'm also glad to be a part of it, because as a community member, it's important to me that our schools and our municipality and any other of these local groups does well, because that's important. When your city is functioning well, your schools are operating, at their peak, that's good for us as a business. So it's important to me, it's a mission that we take very seriously at Hawkins.
Now, Maria, I'm going to ask you to comment on this. So most family physicians do not know, particularly those in academic family medicine, do not know about the value of a community pharmacist. You are not one of the big boxes. You are locally owned, and you make house calls. You will work with people. I want you to comment a little bit more about that service, the personalized service that you provide to patients.
Yes, being the owner of a business, big or small, it's not, there's a lot of challenges with it. But one of the things, even with all the challenges, that's great is if I think that it's important to do something or there's a benefit to doing it, then I get to do it. I don't have to ask corporate anybody for permission, or if they think it's a good idea, or worse yet, if it's a feasible thing. You know, a lot of chains, you're not going to get that kind of service because it just doesn't pay enough for them to provide it. But I understand, having, you know, been born and raised here in this town, how important it is that people get the health care that they need and deserve. And so my staff is always there. It's, you know, we do things like deliver, you know, have free delivery for patients that are in the city. We go out to businesses when they need, like, you know, with the schools, my staff is over there giving flu shots or COVID vaccines or whatever they've needed. If they have a health fair, we're a participant in it. If the schools need donations for things, our group does it. You know, we're very, that's important. And I think you're going to get that if you call CVS. They're not going to drive a prescription to someone's home, or, you know, like I said, put an ad in a yearbook or whatever. It's important to be a team player in the community, and we, you know, always stand ready to do that. And the physicians in our area, in a small town, I think they are very aware of that, because we do get a lot of patients who will say, well, my doctor said just to go there, you know, and we know them and their families. And that's kind of, again, something that makes us different than the chains. When you the big stores, I don't know how much physicians, you know, would know this, but you really are, just like they are driven sometimes. It's all metrics, and you have to meet quotas, and, you know, the chains are also under that same gun. Well, none of my employees are. I can spend as much time as I need to with one of their patients if they need to better understand how to use their insulin or why they're taking certain medications, or to keep things straight. We work with them, and you know, we're just, like I said, it's just me that would make the decision. Are we going to do that or not? So if they have a good relationship with a locally owned pharmacy, when they need help, whether it be for one of their patients, just for themselves personally, you know, we're always there for them. So if they don't know that, they should reach out to the community pharmacy in their area, and they'll discover that that is the truth.
That's fantastic. Bryce, I'm going to come back to you. And you've created this model, and you and I have had a chance to talk about this as you've been evolving and growing. Why don't you give folks an idea of where you're headed with this? What's the plan long term?
Sure. Well, again, I'll say to you that we're really building these type of we call them, for short, COHPs, all across the country. We're helping other advisors attempt to do this, but we have populations that we serve in much of Appalachia, West Virginia, the Carolinas, even Central Florida. We're expanding down to Louisiana and Texas this fall. But every market we go into, we really use the same recipe with nearly the same ingredients. And for us, you know, we just have folks reaching out to us around the country, both, you know, public entities and private, that just say, hey, we want to do what they're doing. And there's not much guesswork. It's not like we're throwing darts at a wall to see the outcomes. It's very meaningful, but the impact that it can make on employees and their families, Casey said it earlier, we're about relationships. We're all independent. Almost all the vendors that we plug in when we unbundle the health plan, independent plan administration, direct contracting with vendors who are not owned by Wall Street or venture capital. We bring the local back to a health plan. And the Norman Rockwell idea of a physician walking in with a medicine type bag into an employer or a house, that's kind of what it feels like, but it's concierge medicine and no misalignment. And so I think I just want to add too, because I think there's probably a group of physicians listening to this. When our nurse navigator works with a DPC, or if they're just doing it on their own, what we're doing to shepherd and redirect and guide people to high quality providers, we're actually investigating and validating every physician our nurses recommend by their NPI number. We look up and we want to see volumes. We want to see the readmission rates, complications, misdiagnosis, infection rates, and mortality. Those things help us guide and get to even a further piece of, well, let's help determine appropriateness and care. Dr. Marty McCary says it very, very much in his both his two books, Unaccountable and The Price We Pay. But we have a crisis of appropriateness in this country, and it goes around the fee-for-service misalignment. And so we really want to make sure that if our nurses are sending just a new mom about to deliver a baby to an OB, we want to look at, well, what's the C-section rate versus standard vaginal delivery, and is that physician doing way more C-sections, and why? And those might be a red flag for us. And so we drill down a little further into the data. Okay, well, let's look at this. And these are the types of things. We're just not blindly steering folks. We're really shepherding them to make sure that they're not going to be harmed financially as well, but really clinically. We want to do our best to make sure we're sending folks to the right people. So we do that. We find the high quality providers, and then we seek direct contracts. We go after them. Let's remove some of the unnecessary middlemen or money handlers in the model, and see if we can do direct contracting in a particular market for our employers.
So that's fantastic. Well, conceptually, the idea of locally owned is very powerful, as Dave Chase is so well written about in his books. But also connecting the important assets within a community so that they can do what they're trained to do, and not have an insurance company or some other third-party administrator interfering. Sounds like really it's the ideal of family medicine, what family medicine has really been hoping for all along. So I'm very excited about what you're doing. We have just a few more minutes left. Maria, Casey, Bryce, anything else that you would like to add for the participants so they can appreciate what you've done?
Sure. So not only the value that we're bringing to folks for making sure that they're getting to the highest quality care options, but the financial freedom that also brings to them is huge. So when a member follows the nurse's guidance, we are able to waive their deductible and their co-insurance. For a lot of folks, that's thousands of dollars a year. Then you layer on top that they get free generic medications at the community-owned pharmacy. Other than premiums, the vast majority of folks are paying nothing out of pocket for their healthcare costs because they have a free direct primary care physician, free surgery, second opinion, referrals if they follow the nurse's guidance, and free generic medications at their community-owned pharmacy. That right now, given the current economy, when everything else is costing more and more, the fact that they're spending less money on their healthcare allows them to put more money into retirement, invest in their kids' future, spend more money locally if they choose to, but it gives them the money back and keeps it out of the hospital and sick care system.
That's fantastic. So Bryce, another question for you. You and I have talked over the years, and you have other employers, not just the school districts, not just the public sector. You want to comment about how this serves for-profit companies?
Sure, yeah, private sector,
Yeah.
for-profit, yep. So again, we replicate the same recipe. We've done extremely well. The worst outcome we've ever driven was an 18% year-over-year savings. Okay, that's the worst we've done. We have we're currently in middle stages with the 7 other public school districts in our county. We're currently in the final stages with the county government. Casey and I had the pleasure of presenting to 62 union members about 3 weeks ago. What we're doing is it's meaningful work, and most would say, like, we now have a reason to get out of bed every morning. It's what we're doing is empowering patients, but it's for all the right reasons. And so Dave Chase will say this every time he speaks, healthcare over the last 30 years is the #1 driver of poverty, bankruptcy, homelessness, and opioid usage in this country. And when you realize that, and again, my passion obviously comes full surface when I get talking about this, but when you realize that at one point in time, we were all a part of that and we've broken away from it to provide hope and dreams and things that, you know, prior to the COVID stimulus, 70% of all bankruptcies in this country were medical bill related, and 50% of those people had health insurance. No longer is that a problem in these healthcare plans. And that's what we're restoring. And so it's very exciting. It just continues to grow. I mean, I've been on the Hill last month. I had the pleasure of going and meeting with senators to try to push forward on this. I've gotten into such a, you know, circle of wonderful people, folks like Marshall Allen and Dr. Marty McCary and Cynthia Fisher, that are just trying to drive hospital transparency and all of the right things for all the right reasons. So it's exciting. And I just love that we've done it in our own hometown. Fortunately, you know, blessed to say, we now are doing more business outside of the state of Ohio than we are in the state of Ohio, but right here in our hometown is what has, it means the most for us and our community.
So I just want to say thank you for your vision. Thank you for your hard work and inspiration. Thank you, Maria. Thank you, Casey. You guys have developed a model that I'm hoping will spread far and wide. We have to get out of, for the reasons that you said just now, to create hope for the working class and the middle class, and to create a better care delivery system for all classes. I like to tell people that even well-to-do people are getting bad health care right now that actually ends up causing harm. They just don't quite appreciate it. But what you're doing is creating a better coordinated system, and the price coming down, the expense coming down is one of the benefits, but the larger benefits is people are healthier.
Yes.
And that's just fantastic. So thank you for being part of this presentation, and I will talk to you all soon.
Thank you, Larry.
Thank you.
Thank you.
Yeah.